Now, so there's a part that you talk about something, and I have experienced it myself recently, actually. So I was admitting a patient who has had intestinal obstruction, a 40-year-old lady, still very energetic, symptoms of 3 days, vomiting very badly, distension. And the relatives asked me one question: is she going to be okay? And of course, having the knowledge, I know surgery can go anyway. So I tell them, yes, most of the people we operate on, they get better, they go home, but it depends with what we find in the operation. But they kept insisting, is she going to be okay? And for a moment, I was dumbfounded. And when I was reading the book, I was like, yeah, I'm seeing here. You call it Loliondo hope, the hope of Loliondo, giving hope in the surgical field. Sometimes you don't want to overpromise. Sometimes you can be 100% sure, but you don't want to say it. But when you go to other places, when I go to church, for example, it's all 100% hope. Let's talk about that.
Listen to these numbers.
Yeah.
No,
Yes.
yeah, indeed, indeed. No, that was fascinating for me.
Yeah.
It was during internship. I think 2011 is
Mm.
really when the issue of Bagua Loliondo
Yeah,
made
yeah.
headlines. And later on, when I went to Kilgoris for my posting, I actually found it firsthand. Patients who are defaulted on their second line medication for hypertension, for HIV, coming in extremely critical conditions because they are dropped and they went for the hope. And and I looked through, and the question I kept wondering is, what exactly is it that the Loliondo guy did?
Yes.
He gave them hope. He gave them hope. And sometimes we don't give the patients hope enough. There's actually research, especially around oncology. And just the other day, last week, but when I had a patient who we had operated, we found incidental gallbladder cancer. We sent her to the oncologist. We had some scans and we agreed. We feel like we've removed it, but because of how we found it, and when we removed the gallbladder, it wasn't aggressive surgery with the thinking that there could be cancer. It is only fair that you get some um, some chemotherapy. And she went round until she was almost running out of time for chemotherapy because she didn't want chemotherapy was associated with hopelessness. So in cancer, it has been found, especially terminally healed or advanced cancer, that most of the time the patients fear that when you're telling them this is palliative, this is terminal, that you will leave them to die by themselves. And all we need to tell them is, we might not cure you. We will manage you and we will be here. We will be here anytime you need us to be here. And on top of the Leodo story is the lady I saw with cancer of the colon. And we judged that this was really widespread, but we diverted to the colostomy. She got stronger, and now we planned to do either debulking surgery or just give her chemotherapy. But she went to alternative medicine, and again, just like Loliondo, because the guy told them, "Oh, send me the CT scans." They sent the CT scans. What has the doctor said? With this, give me 200,000, and I guarantee you. So they sent 200,000. They never came back to me. When they came back to me, they told me. Actually, they called before coming to the clinic. We went to alternative medicine. We have been given some herbal concoction. Now it must have wiped everything. We want to know which investigation to do to confirm. So I told them to do a CT scan. And when they came, the tumor had advanced. But it was worse. It was worse than it had been. And it was there, and I showed them and I asked them, why did you go to this person? And they said, this guy gave us hope. And that was also another wake-up call for me. I must have been looking unconcerned. I must have not given them enough hope, and they just looked for someone who would give them hope. So it is natural. It is natural to as a human being to really cling to hope. And I think for me that was a wake-up call for myself and for any colleagues who probably interact with such patients. Yes, they might have the terminal disease, that they still need the hope that you will be there. You must give hope. Tell them. And most of the time, the much you need to tell them is, we are going to be here. We'll help you, whatever you need. Yes.
Now, and I think the issue of hope does not depend on education level or culture. It's across. Eh, The story of Lolondi you clearly mentioned, it was everyone, from the low socioeconomic status to the highest of politicians and business people.
In fact, there
What
was
does that tell us about our brain and our life as human beings?
we are all existential. We are all human beings with an evolutionary angle to it, and therefore anything that will threaten your life suddenly has your attention. Anyone, even I think there was some royal family also that went to Loliondo. So anyone, and stories are there for people, big people, including professionals, uh, including prominent doctors who will want to say, no, I don't want that. I don't want that. Why? Because suddenly the issue of being professional is put aside. Now this becomes existential, extremely personal, extremely vegetative. And at that moment, you have to meet the patient at that point. And sometimes when you have been, a doctor for long, things that scare people stop scaring you. But then you shouldn't forget that people are still anxious when they are admitted. People are still extremely anxious when they have to go to hospital. I have been admitted, I've been operated. So I also thank God that I have had that experience as a patient and as a doctor. And hopefully that helps me understand people's experiences. It hits different.
Yeah.
That helps me understand patients' concerns. But really, these are real concerns. These are people who do not know what is the prognosis, what is the possible outcome of the disease I have. If you tell them, you have a small growth on your on your finger, it is called a pyogenic granuloma. I'm using a technical term which you know, but it carries 70% chance of death. Do you know they will believe you? They will say, doctor said this one will kill 7 out of every 10 people. So that aspect, the doctor is so revered because then you are coming almost assisting God, almost playing God in some instances, because then the question that when I'm struggling to understand why am I sick? Why am I getting cancer? Why did I get this rare disease? Why can't that mean neighbor be the one getting this? When you're trying to bargain and getting frustrated and getting angry, you don't have a God to ask, you don't have a deity to ask. And sometimes it's just the doctor you are asking, and then the doctor also can't understand what's wrong with you. I told you have malaria, you take these drugs, in 5 days you'll be better, but you can die. So for us, it can be really cutthroat because we are professional, and sometimes we are not able to meet that aspect because every treatment, be it medical, be it surgical, it's always biopsychosocial. So there's the psycho aspect, there's the social aspect, and the spiritual aspect, which reaches everyone. Because everyone is really vegetative. There is one person who used to say, if you fear your boss so much, whoever boss, wherever you are, even the biggest person in the world, imagine them having diarrhea. Because then suddenly you realize everyone is human, because you will run to the toilet, you have to do this. So everyone is human, besides all these accolades they get or the transient powers they wield. The moment the biology misbehaves, then everyone realizes 2 things. One, I can't treat myself. So therefore I need to supplicate to someone. But also there is a lot of imperfection. And because of that, there are no sureties. So people get anxious. People get absolutely anxious. And, once in a while, that is not something you are able to adjudicate completely. But just to offer listening ear, just sit there and do nothing and tell them, okay, I'm here to listen what fears you have. Do you want to postpone? Just before we started, I was talking to my colleague of a patient and to postpone surgery. I think they need surgery. I came to them and they told me, I am not ready to have surgery and I want to talk to a pastor. Those are not the days you rush to theater. There's something higher to them, speaking to them. So I was like, okay, fine, we don't have to do surgery today. We will send our chaplain, we'll have a talk. And when you're ready, we will go. So those things, unfortunately, you learn as you grow in the space. Yeah, because every time a patient brings the question, am I going to be okay? Am I going to be okay? You start thinking about other things. And I wrote that about that in my first book of this patient who we were removing a simple, straightforward lump. And they came and told us with the professor, I feel like I will die. And we're like, what's wrong with you? It's just a small lump. You won't even sleep. We'll just put what is called local anesthesia. And then we went in and put local anesthesia. Local anesthesia did not take. We got to the maximum dose of anesthesia. So we stopped. Then we went to general anesthesia, but through what is called LMA, which is going to be short. Then we finished. Then by the time we finishing and saying now you can remove the LMA, she got reactions in her airway, what we call bronchospasms. And now the airway is blocking, she can't breathe. So we had to intubate and then take her to ICU. So she had come in just for a lump to be removed in 20 minutes under local anesthesia. She went to ICU. And so therefore we learned to know that there could be something superior that we don't understand in the biology that is talking to the patient. In her spirit, she was like, I see myself dying. And there are those things we really can't tell patients because what they feel is what they feel. Is their body speaking to them. And there's a lot we yet do not understand about the human body. And when you don't understand, it's better to say, okay, I don't understand that. Let me listen to you. What would it be?
Fantastic. Let's talk about something else. This conversation is interesting. As we continue, we're talking about wisdom, bled wisdom, right? A surgeon's guide to life beyond the theater. Let's talk about something personal a bit. You talked about at every stage of your training and practice, you feel like you're always the younger one.
The elder one.
I mean, the older one, yes, the elder one, yes. Let's talk about that in line with what you call the concept of age and time, and then also set timelines. Yes.
Great. Yes, indeed. When I was growing up, this is chapter 2 of the book. When I was growing up, education wasn't really priority. I've spoken to this previously. And we grew up to herding goats in the lower plains of Meru North, at Wansi Isiolo. And then eventually there was an outbreak of a livestock disease that decimated the herd of goats that I had. Eventually, by the time we went to school, I was 8,
You said
9.
in the book.
So 9 is class 1, yes. But I had done like a term in nursery, and then I dropped out again and went to herd goats.
Oh, wow. Okay.
But it never hit me that I was that late to join primary school until I got to, even when I got to high school, I was like, wait, I'm graduating 2002, I'm 21. How am I 21 with an ID? And in Form 4, what is this? But when I got to university, it's really when I realized every group I was in, I was 4 or 5 years older. Unless there was someone who had come for module 2. They had done a first degree, and therefore they were coming. Now there I was at home.
That's not in medical school.
Yes. So by the time I was finishing medical school, I was like, my goodness, I need to really catch up. I really need to catch up because this is not fair. And as I knew, I want to finish internship and go back to postgraduate. And when I went, I did that. I finished internship. I was posted to Transmara I reported, I think, 2nd of June after Madaraka Day. Is it Madaraka Day? 1st of June is Madaraka Day, right?
Yeah, I think so.
Yes. After that, I reported. And then in August, I interviewed for the postgraduate program in Aga Khan. And I got the admission confirmation that I passed the interviews in October. And then I decided in November and December, I was moving house and coming to Nairobi from Kilgoris to start my residency in January.
How many months after internship?
This was 6 months.
6 months.
6 months. I just worked 6 months. But in that interview in August, the late Professor Hassan Saidi asked the question, which I speak about, asked me, where did the years go? Where did your years go? Yeah. How can you not have repeated any class in primary, in secondary, in university, and you've just been less than half a year after internship, and you're still that what, 2011, I was going into that, 2012, that one, 2012. Yes, so 2012, why are you that one, and you've just finished internship? Yeah. And I couldn't answer. But it still plagued me, and therefore I developed this sense of urgency. But
even before he asked you, you already had that insight.
Yes, I already had that insight, indeed. I already had that insight from right when I was going into internship. Yeah. But now, when I mention now, it doesn't make sense any longer because yeah, you in fact, one a person told me, no, now that's no longer a problem. You're no longer the oldest in the group, because now if we sit in a group of surgeons, I am no longer the oldest, so I don't have to feel that. But that time there was that sense of urgency. You speak about setting timelines. That is one of the lessons I see I learned from intestinal obstruction, even from labor, all those things. Why? For several reasons. They say if you're in a room with 8 people, one person could be having a mental health issue. Is it anxiety? Is it depression? And when you look at the various explanations that psychologists and psychiatrists will advance, most of the causes of this anxiety and depression, mental health issues, is when someone has a lack of control. So you can't control, you feel overwhelmed, you feel like this is not something I can control. And that happens to us a lot. If I did not carry the umbrella and it rains, I can't control the rain. So that's a stressor, isn't it? If I've done a job interview and I'm waiting for the feedback, I don't know whether I will be called or not. That is a stressor. And now I'm stuck here. I don't know what to tell the landlord at the end of the month, because I was planning to, kind of just leave. So I share the story as one of the lessons we learned from intestinal obstruction. The cardinal, one of the mantras in surgery is you should never let the sun set twice on a patient with bowel obstruction, because what you do with bowel obstruction is, majority of them will unblock. If you just give them fluids, just put the tube to suction out the contents of the stomach, don't feed them, just watch them. Majority of them will not need surgery. But who really determines who needs surgery is not the surgeon, it's the patient themselves. And therefore, if the surgeon has no control, then how do you take back the control? Because you can't just live perpetually. So you just set a timeline and you just come tell them this and this and this, and 48 hours. In 48 hours down the line, if you've not opened up, we are going to theater. We do that on a day-to-day basis. Even yesterday, probably you did it. In your patient, you told them we'll conserve, and then if it doesn't work, we'll go to theater. And therefore, that is how the surgeon takes control, because these things were under them. But the moment I walk into the ward round, the stress of saying, oh, what has the CT showed? They are changing the lab. It doesn't matter. When it's 48 hours are passed, I'm like, you've not opened in 48 hours? It's a busy. Let's go to theater. Then you go to theater, then you realize, oh, it was just an adhesions bud, or it was a tumor, or it was a twist, whatever it is really. Of course, there are several. That is the simplistic overview of it, but there are several other nitty-gritty things. As you become a specialist, you're able to pick that doesn't necessarily have to render itself to the 48 hours. And there are some once in a while you can actually push past 48 hours, like if you have scarring, what is called adhesions, and actually sit longer, as long as you are sure of other things. So that lesson, I found it very useful up to date. And I dish it across every single day. Even yesterday, I dish it across. This guy is not picking my phone. I need to make a decision. I'm like, okay, set yourself 2 hours. If they have not answered, take the decision. But between now and those 2 hours, you will be the calmest you have been. Because now you don't have that constant barrage and stress that, oh, why are they not picking? They don't like me. They are belittling me. I will write to them for insubordination. Hey, relax. Maybe they are sick. Maybe their phone has been snatched. There are things you can't control. Yeah, so I personally live that. I will come into a hall. The queue is not moving. And I will say, what time do I need to set myself? 45 minutes. I'm like, 45 minutes, if the queue has not moved, I will go. Yeah, so you are able to assess a lot of parameters and say, really, given all this information, there is this bit that I can't control. And it can be better, it can be worse, but I can't control. The only way I can control is to set a timeline. So for me, the lesson from the blocked bowel is, if you're not in control, because that is a stressful situation, give yourself a timeline. That timeline you have given yourself will give you power to decide to do whatever you do. And once you've done that, the moment you take whatever step you take, it might not be popular step, but you have a method to it. So you will say, I set a timeline and I acted based on the information I had. In another day, if I had set a 1 hour timeline, I would have waited. But now it was 48-hour timeline and didn't work. By 48 minutes, I was gone. Yeah, I that is probably my favorite. That is probably my favorite.
So in life, for example, for those who are not married, if the relationship is not working, you set a timeline. If the business is not working, Say I'm giving this business 1 year. If it's not working, maybe I should reconsider. Something like that.
Something like that. Indeed. Of course, with quite some data. If it's business, you have got your business development guys who have done the feasibility study and you have exhausted the strategies that you had. You say, okay, everything we have put in place. So it's usually not just to fold your hands and say, for it, the time itself will not do much. But at least you will say, I have put all the structures in place to work.
And you are monitoring the parameters.
And I'm monitoring. But I have these red lines that if they are crossed, one of them is the time, then I will move. So that kind of quickly refocuses everyone. Otherwise, you get into tunnel vision on everything. You focus on, can we hire another marketing manager? Can we now start approaching this company? Do this. And you do that for 3 years. And you are still sinking more debt in terms of maybe his rent, his statutories, his salaries and all that. And just, okay, guys, let's agree. If this is not working by this time, call it quits and move. So that is something that anyone can apply. Absolutely. Once they have put the necessary things to work. Yeah, I mean, if the relationship is not working and you know you are giving your best, it would make sense. But also you can't do the minimum and then say, for 8 hours we'll do miracles, or 1 year we'll do miracles. Then you won't be truthful to yourself.
So in summary, setting the timeline works best. You have put in all that needs to be put and you are monitoring the parameters. Absolutely. If you've done all that and things are not moving, then have the red line.
Absolutely. At the red
Fantastic.
line, that is time-bound.
Yeah. Last thing we want to discuss, and then we will ask the viewers and the listeners to get ready for the book launch. Let's talk about personal things. The rigorousness of the medical training, and not just in training, also in practice. One of the articles you capture of one Dr. Keith Ndindi, the cardiothoracic surgeon, a very long LinkedIn post, where he talks about the challenges of family, marriage stability with the medical people. Let's talk about that briefly,
Yeah, indeed. There is, we opened that chapter, that part with the sleep when you can, eat when you can, and don't mess with the pancreas is a mantra in residency, to say sometimes you are so hungry but so sleep deprived that probably you just stop to sleep, because that is how rigorous the training is. But Did captures it so well. It says the world has moved, and it's time that we looked at not people's inability to get tired. It's time we also looked at, okay, how can we make it easy, enjoyable? Because if you enjoy shooting podcast, and then we have a training program that allows you an hour to have a conversation, when you go back, you'll be more productive, because that is slightly higher thinking than straightforward thinking. Previously, granted, the supply of doctors was short. The diagnostics and all these simulations were not there. But now these things have come. So you have more doctors who can come into the program. You can clock in all the hours, but you can also go and sleep and wake up in the middle of the night and simulate a case and do it on a virtual or mixed reality patient who is not a real patient. And even that also clocks the hours. So Didi speaks a lot to that, and I am hoping you'll be joining me for the launch, because I would want him to speak to that a little bit. I will find out if he's back from the US. But the thing is that dichotomy has been there. And one of the senior colleagues, not a surgeon, but a doctor, is the one who even told us sometimes back when he was leading students, he just went and asked the professors, sometimes you're expecting a lot from us undergraduates. Aren't you expecting too much? Are you sure the way you are expecting us to behave is the way you are behaving at our age? Yeah, because life has this way of you not being able to put things in staccato, block by block. If I look back and you ask me, okay, how you speak like that and how you take that suture, which day and time did you learn this? I cannot give you that because it's graduated. But where I am, if I look at a first-year resident or an intern, I might wonder, why don't they know this? What do you mean they don't know this? And then if you actually asked me and pinned me down, when did you master this? I might, there's there's a likelihood to over exaggerate. But probably I was also at their age, I was also really bad. Now the reality is there are generational shifts, like you just spoke in the show. There are people who are like, why should I be at work after 5? Hey, boss, toxic, move out. And then if you, I'm like, dude, how can you leave your patient without an exit round? I am here at 6 in the ward. Why aren't you here? So there are those generational changes here and there. And I think the thing that needs to look at addressing the program is, first of all, the programs themselves. And Didi speaks about a program he was in, which was brilliant. At 5, you are not on call, you go. Because then they know you go rest, and then tomorrow you come and you give in your best. When you are rested, refreshed, energized, you have done other things that really excite you and make you glow. So it'll be better than someone who has been there all night and is gloomy and grumpy to the patient. The programs have a work to do. And I am sure the academic directors will do that. The professional societies have a work to do. And I think all those can be fixed through mentorship, that people will gravitate to people who can mentor them and tell them, okay, so this is what we do, and this is what we do, and like that, we don't do that. I feel like there's a personality aspect to it also. When you look at the personalities and the personality types of the various disciplines, then maybe the more go-getter, aggressive personalities might find themselves in the surgical disciplines, and therefore then surgical disciplines look a little rough and might be too daunting on the person. Yes, but granted, the kind of training that one goes through in surgery is still intense, irrespective of where they are. It's still intense, but I feel people can put in place measures to make that a little better. In some places, it's gone overboard because it says you have a pager. If you admit 8 patients, good, your shift is gone. We don't care whether you admit all 8 patients in 2 hours. Go, because they want now to improve. The others say you have a pager. Even if you have not admitted a single patient, when you finished your 8 hours, hand over the pager, and you know it is monitored, so that then they avoid this aspect of burnout and workplace brutality and all that. So it's a nuanced thing. And then when you look at those programs, the people in surgery refuse, because they are saying, just when I've admitted all the 8, and 3 of them are nice gallbladder and appendix, and I want now to do them, now you're telling me to go home. I'm not going home. So it has both aspects. So when you go to those programs that are robust on, you clock your time, you go, so that we take care of you from a mental health wellness aspect. The residents actually start defaulting and start saying, no, I really want to scrub in. I really want to scrub in and do that surgery because I'm the one who admitted. Because then why should I admit and leave Chelsea to do? Yeah. So it is so nuanced that you just have to find situations that you can work with. And there's a lot of work written around how to make that easy. Mentorship, there's a whole book by Mwachiro about mentorship. And I think that's the space that will work. But I think what we need really to get away from is the thing that Didi spoke about, saying that the divorce rate is 150%. You can't use that. I mean, that's really brutal.
The person was saying that's a pride point.
Yes, I'm like, this is the selling point. Whoever survives, I'm like, this is not the academy of the military. Try to make it adjustable, because then you're looking at the output maybe in a quantitative aspect or in a really negative aspect, instead of looking at the other way and saying, oh, this is the best program, everyone thrives.
All right. Thank you so much, Dr. Stanley. We've had a very fantastic conversation, learning from the ward, the theater, and to life practical lessons from you developing your idiosyncrasies, kind of like your bias, right? And identifying your gallbladder and getting them out of your life when they cause problems, setting timelines, okay, and having a balanced life. So there's a lot to talk about from this book, Bled Wisdom. But to get more now, we have to agree that you are going to show up in the book launch that is coming up very soon. So I want to request Dr. Stanley to just talk briefly about the book itself, and now the dates of the ceremony.
Fantastic.
Yes.
Indeed. 21st of March, 9 a.m. I have Lavington. Please come. 20th is going to be Eid al-Fitr. You will have rested. come early in the morning, there will be no traffic. We'll have a fantastic lineup. We'll have a panel discussion, fantastic moderation, a keynote, and then live reading, and then we launch the book. But before that, you can actually pre-order. You can pre-order now. The pre-order rate is discounted 1,800 shillings. Just get on mysterypublishers.com. They are the ones who are publishing. Mystery Publishers website, you will find a pre-order there. Any of my socials, I have also put in the pre-order link form, and you can link and tell us if you'll be attending, if you consent for photography, and then you do payment through the pay bill they have given there, and then when you come, you just collect your autographed copy. But I really looking forward to have people interact with this content and tell me how they think about it. If at all it helps demystify the surgeon, and pick one or two things that each of us can employ in 1 or 2 days of our life to make it better for us.
Fantastic.
Yes.
So the date is
21st of March,
21st
2026,
2026.
from 9 a.m. to 12 noon.
Fantastic.
Yes.
All right. Now, why did you write this book? Why? Bled Wisdom.
Interesting. Why?
Why did you write this?
I under each.
Yeah.
I under each.
What was the why for the writing?
Once a writer, always a writer,
Yes.
I feel. But I feel the greatest form of value add you can give is to give an idea that somebody else can find useful. And therefore, besides removing patients' gallbladders that are anatomical, what if I helped someone else remove their gallbladder that is not physiological, psychological? And the other thing is maybe to just make people understand what is surgery, what goes on there, what things do you do? So I felt it's important to share that kind of content and hope people find it useful. I gave myself that commitment when I launched my first book. My first book was just to talk around things that we do. When we went to my colleague's launch the other day, one of the things that came up is the rest of the world, the Middle East, the Europe, the Americans, they have been writing and reading for decades. For us in Kenya and in Africa, maybe reading and writing, we have interacted with it, especially writing books and reading, we have interacted with it for less than 100 years or thereabout. And therefore, we are behind. We lag behind. Yes, we lag behind, and we need to keep telling our story. Because if we don't tell our story, then no one else can tell it. So each one of us has their story to tell. I felt this is a story I did not tell in the Chronicles. And the other story is now probably the next one might be around the C-suit. But before you get used to it and say, this is how life is, imagine someone who is coming for the first time. So I felt it's important to share this to communicate as a form of communication.
Fantastic. Thank you so much, Dr. Stanley. As you've heard, 21st March 2026 from 9 a.m. to 12 noon at iHub. All right? So save the date. Come. It will be on a Saturday. So there will be no going to work. Saturday asubuhi by saa saba, we are back to our families to end it out with our kids.
Yes.
Yes. Now, as I conclude this discussion today, one of the things I have always gotten feedback from other people who are not in the medical field, people appreciate writings by medics, especially doctors, that there is a way medics deliver knowledge in a way that is, somebody can write a book by Googling, like you are writing an abstract thing that you have not experienced it yourself. But this is experiential. This is purely experiential, something he has lived, he has done, and it's lessons that he has practiced and seen in other people. So that is one of the values that you might be asking yourself, why should I come for the launch? Why should I buy this book? It's real life experiences, no theory, purely practical, and something that you can directly translate to your life. So I want to make the call that you show up in the book launch. Through the social media links, you can book, you can get the book order and confirm your attendance at the book launch. And we'll be happy to see you. I will be there. he will be there
I
with
will
other
be there.
people.
Yes.
Yes, thank you so much and cheers. God bless.